All right, hello and good evening, everyone. Welcome to our 31st Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia, and it's a pleasure to have Dr. Sofoniyas here with us, and he's going to give us a presentation on the acute pain management. So to give you a background about Dr. Sofoniyas, Dr. Sofoniyas is an anesthesiologist and a critical care pain medicine specialist working at the St. Peter Comprehensive Specialized Hospital.
Okay, thank you. So as he has introduced you, good evening everyone first, and I'm Sofoniyas Getaneh, anesthesiology and critical care physician at St. Peter Specialized Hospital. Today we're going to be talking about acute pain management, and pain management is a very broad topic, so we have limited our presentation to acute pain management first, and most of these are extrapolated from perioperative settings but can be applied in any hospital or mostly in critical care service as well. So with no further ado, I will proceed to my presentation. So this is going to be my outline. We'll try to go through the introduction, so see some classification of pain. So we'll go through the mechanisms and methods of pain assessment, also modalities of treatment. So pain has been defined in 1986 by Martyrs as an unpleasant sensory and emotional experience with actual or potential tissue damage, or described in terms of fresh tissue damage. So there is a sensory component as well as the emotional experience, which will be associated with chronic pain or acute pain, and also the potential tissue damage underlies a main issue. So one thing to understand is that pain is just a subjective issue. So what might be painful for me may not be painful for somebody else, or the extent of pain I feel or I experience may not be the same for another person. So you cannot guess a patient's pain experience as with somebody else's experience or our own experience. So nociception, to define the term nociception, it's derived from the Latin term noci, and it's to describe neuronal response or neural response to traumatic or noxious stimuli. So you will be using these terms in the subsequent slides. So to classify pain, there are many grounds to classify pain. And the first one is temporal, which can be classified as acute or chronic pain. And acute usually lasting between days and up to 3 months. Sometimes they give it up to 6 months, but mostly 3 months. So we'll be defining chronic pain as a pain that lasts the time of 3 months here. So pathophysiologically, we can define as nociceptive pain versus neuropathic pain. So nociceptive pain is pain that arises from damage to neural tissues, or tissue damage or inflammatory activation of nociceptors, while neuropathic pain arises from inflammation or damage to nerve tissue. It could be a transaction, it could be a compression, it could be ischemia, but it's all associated with the nerves. It could be central and peripheral. So we can define it as such. Also, we can classify it as from its etiology. So like postoperative pain, cancer pain, arthritis pain, and as such. So acute pain, it's caused by noxious stimulation due to an injury, a disease process, or an abnormal function of a muscle or viscera. So there are many components, and it's usually nociceptive. So there is painful stimulation of nerve endings. So nociceptive, and it serves to detect a purpose, that is to localize and limit tissue damage. So there are 4 main processes involved in this. The first one is transduction, the second one is transmission, the other is modulation, and the fourth one is perception. So by transduction, we mean when there is a damage to, or when there is a trigger that elicits nociceptors or activates a nociceptor, there will be generation of action potential. So there will be release of neurotransmitters such as histamine, bradykinin, leukotrienes, and also TNF-alpha this will produce an action potential that will be generated and transmitted, which will be the second step, transmitted to the spinal cord. So the gray horn of the spinal cord, or the dorsal root ganglia on the spinal cord, will be activated, and it will pass up through the ascending passageway. So the third one will be modulation of pain. After the pain is transmitted from by the peripheral or afferent nerve endings to the spinal cord, which will cross to the other side, and through the spinothalamic tract, it will go through the central nervous system, which is going to be like going to the thalamus. So there will be sensation there, there will be perception there, and also midbrain will be stimulated, and there will be modulation there as well. So it's typically associated with the neuroendocrine stress response. So that's what makes acute pain differ from chronic pain mostly. So neuroendocrine stress response is mostly absent in the chronic pain. So this neuroendocrine stress response is mostly responsible for the pathophysiology or the physiologic consequence of pain as well. So this is usually proportional to the pain's intensity, and the mostly the commonest manifestation of the neuroendocrine stress response is activation of the hypothalamo-pituitary adrenal axis, which will result in the release of cortisol. Also activated is the renin-angiotensin system, with release of angiotensin 2 will lead to vasoconstriction or salt and water retention, and also release of ADH, which will lead to salt and water retention as well. So mostly this will lead to the physiologic effects of pain. So this image depicts, as you can see, there is a tissue injury which results in inflammation and mediator release, such as those mediators such as substance P, prostaglandins, serotonin, and acetylcholine. So they will be sent to the spinal cord. So after they are sent to the spinal cord, they'll pass through the spinothalamic pathway, and they'll pass to reticular activating system and the thalamus, also the somatosensory cortex, which will conceive it as a pain or as a painful sensation. So continuing with the neurobiology of nociception, there are two concepts which are essential for our understanding. So once there is an intense noxious input from the periphery, it may result in two things. So one is central sensitization, which is persistent post-injury change in the CNS that results in pain hypersensitivity. So if someone is exposed to a painful stimuli, next time exposed to a lesser stimuli or a less painful stimuli, maybe he will conceive it as a painful stimuli again. So the intensity might be exaggerated here. So that is one concept. And the second one is hyperexcitability. So exaggerated and prolonged responsiveness of neurons will be the result of hyperexcitability. So patient might become hyperalgesic. So these things are basic because these two concepts are what leads to development of chronic pain in the times to come. So the other, passing to the consequence of poorly managed pain. So as I told you, there's the neuroendocrine stress response, which is mostly responsible for this consequence. The first one is coming to the cardiovascular. It's tachycardia. Patient might have a tachycardia, hypertension. So there will be sympathetic activation. So there will be increased cardiac work or myocardial oxygen consumption. And this might tip patients who are at the age to develop a myocardial ischemia or infarction as well. So coming to the respiratory, patients might splint and they might not breathe well. For example, if a patient had a surgery for an abdominal or a thoracic procedure, if you don't serve his pain analgesic requirements well, patient might split and he might have a decreased vital capacity, atelectasis, hypoxia may accompany. And also where in the level of the spinal cord, there will be modulation of this afferent stimuli. So there will be inhibition of this stimulus. So patient might splint, or inhibition of the diaphragmatic function may happen, and patient might splint as well. So it's a two-way street. So increased risk of pulmonary infection is possible again. So on GI also postoperative ileus is possible. coming to the renal, increased risk of oliguria and urinary retention is possible. Coagulation can happen, like increased risk of thromboemboli. This is due to an imbalance between procoagulant and anticoagulant factors. So patient may be bedridden, and there also increase in procoagulant and decrease in anticoagulant factors. Also, there will be a decrease in fibrinolytic factors. This is all because of pain, and also due to the increased cortisol levels, due to the increased cortisol levels, as well as due to the hyperglycemia, there will be impaired immune function. So muscle coming to the muscular system, like there could be muscle weakness and fatigue and increased risk of DVT again. And passing to the psychological part, patients might feel, or patients might develop anxiety, fear, and frustration. And we should not neglect this component as well. So how do we assess pain? So there are many things to assess. Mostly it's advocated as the 7 attributes of pain, such as site, onset, character, associated factors, the timing, the exacerbating or relieving factors. So we can classify it as such, but it should be assessed in a very detailed manner so that we could tell the cause of the pain, and we could manage our treatment or guide our treatment by going through that. So the quality could be dull, sharp, throbbing, or shooting, or burning. So for example, here shooting and burning are commonly neuropathic type of pain, and dull, sharp, dull pain could be from a visceral type of nociceptive pain, or a very sharp nociceptive pain can happen in somatic types of nociceptive pain again. So duration can be constant, intermittent, or paroxysmal, and we can classify it as such. And also we should assess the patient's expectations, because how we are going to manage depends on patient's expectations. For example, if a patient expects 100% relief, and if you give him a 50% or a 70% reduction in his pain symptoms, that may not be enough, and he may tell you that he's not satisfied. So you should assess the patient's expectations or his approach to pain and his stress and pain coping strategies. Okay, so also his analgesic therapy preference. So after assessing pain, we should also rate the level of pain somebody has. So how do we do that? So we do that by using pain intensity scales. So there are numerous pain intensity scales, more than 20 or 30, and there are some classified, but we'll try to go through some or few here. So pain intensity, as I mentioned earlier, can only be determined by the patient's report. So that's the best way to assess a patient. And measures of pain intensity are not meant to compare one patient's or one's pain with another's. And these tools are used to detect the level of intensity or the intensity of pain someone has, give or guide our management, and later assess his response and act accordingly. So this is the main purpose of assessing pain intensity. So some of the commonly used tools are, for example, the visual analog scale. As you can see, there are two endings. The first one on the left is being no pain. A patient might have no pain, and the last one being the worst possible pain. So you'll explain to the patient that this will be a 10 centimeter line, and this is a level of no pain where you feel no feeling or no harmful feeling or no painful feeling. And imagine the last task, your worst possible pain, and you'll tell him to point where he feels or where his feeling resides. So you'll point to a level, and you can measure that, or you can estimate that and rate or treat the pain accordingly. The second one is a better one. So it has its own markings on a 10 centimeter line, and you ask the patient, 0 being no pain and 10 being the worst pain that he has experienced, where he feels his pain. So those will be some ways to assess pain. So the other is, for example, in children, for example, above 3 years old, you can use this tool. This is called the Wong-Baker Face Scale or Face Pain Rating Scale. So you show them this, and the first patient is a happy one with a happy patient with smile who's smiling and feeling no pain, and the last one is a patient who feels pain and might necessarily not be crying, but he feels a whole lot more or a whole lot worse. So you'll ask him to point to a picture which describes his pain very well. So he'll point to a depiction which points his level of pain, if you understand. So then you'll take the number and you'll assess and manage accordingly. So the other is the revised FLAG score. This is also a pediatric pain assessment system. So there are categories which are rated up to 2, the face. So there are like components such as you can see, like facial expression, legs activity, and cry or consolability. And this depicts the patient's behavior or condition. So children might not be able to tell you. The difficulty with children is that they don't express their feeling or they don't express their pain unless they're a little more grown or like above a certain age. So you have to try to assess through a variety of categories. So for example, facial expression, a patient might have no expression at all, or on the other extreme, he might frown, he might have a clenched jaw, or he might have a quivering chin. So there are distressed looks here. So with legs, you can see their normal position or relaxed. So you have to observe the patient and you have to assess these parameters. So the legs may be drawn up, or he might be kicking, or in some patients with congenital or cognitive disorders, they might have spasticity or constant tremors. So these are good tools to assess children's pain. So you could go through these ratings and you could classify as mild, moderate, or pain and manage patient accordingly. So verbal methods of pain assessment, there is the verbal rating scale. So you'll ask the patient, how strong is your pain? So there could be, and he might answer like as no pain, mild, moderate, or severe. So this is a very simple one, and you could manage based on this. So the other category of patients are the critically ill patients. So here, some patients may be on ventilators, some patients may not be expressive. So you have to assess again with different parameters. So the first one is facial expression. Patients might have relaxed facial expression. We call it this one, the behavioral pain scale. So the facial expression might be relaxed, or at the other extreme might be grimacing, or it might be partially tightened. So coming to the limbs, you can see that a patient might have no movement, or he might have a partially bent, a fully bent finger flexion with permanently retracted limbs. So the other is compliance with mechanical ventilator. So he might be tolerating the movement and might be stable, but on the other hand, he might be unable to control ventilation, or you might be unable to control the ventilation. So anything less than 5 tends to be mild, and above that goes through moderate and severe. So the other one is a critical care pain observation tool, and it's more or less similar to this, except it has another component, which is muscle tension. So these are some ways to assess pain in different groups of patients. So coming to the pain management, so after we assess, we have to manage. So there are different methods to assess, to manage pain. And the first one is a non-pharmacological methods. So you could try cognitive behavioral approach, such as passive relaxation, distraction, music therapy, hypnosis. These tend to be weak during acute pain, but this, I just want you to know these modalities and some of the physical methods that inhibit that activate the inhibitory paths could be like massage, cold, heat, immobilization, or transcutaneous electrical nerve stimulation. This could be possible non-pharmacological methods. And the main topic that we're going to see today is the systemic pharmacotherapy, and there are also components of regional anesthesia. So another concept is the issue of multimodal analgesia. So definition and purpose of multimodal analgesia can be seen in 3 ways. The first one is like the pre, intra, and postoperative use of pharmacological and interventional techniques. So this is with the aim of decreasing the magnitude of the pre, intra, and postoperative pain. So the second idea is utilization of the same techniques during the same time periods. So this will lead to a decreased opioid needs or post-operative opioid requirements and associated side effects. So the third one is prevention of development of chronic post-surgical pain. So one of the most common causes of chronic pain is untreated or unaddressed acute pain. So we don't have to be we have to manage acute pain accordingly so that patient feels comfortable for now, or patient may get relief for now and recovers well. But also there is the concept of chronic pain, which might develop in certain period of time. So another topic or another concept is preventive analgesia. So this started as preemptive analgesia. So the concept of preemptive analgesia was analgesic strategy which was administered prior to a surgical incision. So this was ideally planned to remove the first neural stimulation or release of neurotransmitters, and this could modify peripheral and central nervous system, like avoiding central sensitization or hyperalgesia. So processing of these mechanisms were inhibited, but the argument is that this the main aim is definitely to reduce central sensitization and hyperalgesia, also allodynia, and the results remain controversial because that once the drugs you administer wear off, and for example in a post-surgical patients, like if the drugs have weared off, and there will be the inflammation, of course, and this will obviously trigger painful stimuli. So once the surgical stimulus is still there, so you have to come up with a better method to address this analgesia. So a broader concept, again, is the preventive analgesia, which is to reduce sensitization by preoperative, intraoperative, and postoperative noxious stimuli by treatments administered at any time. So it could be at any time. So these drugs could be given at any time during the perioperative period. So the other one is WHO analgesic ladder. So this was mainly derived for cancer patients, but later was later was absorbed into a general population. So initially there were 3 steps. So the first one, for mild pain, you could start with non-opioids and adjuvants, and the step 2, weak opioids for mild to moderate pain with non-opioids and adjuvants, and the third step was opioids from moderate to severe pain, and non-opioids plus adjuvant. So this concept has grown today to a 4th step, which includes invasive or minimal invasive treatments and interventional techniques. So the first one was mainly derived for kind of chronic pain, but now you could go from the step 4 to, or from upward to downward for acute pain patients. So this difference has happened over time. So the concept is that you cannot wait for an acutely ill, or for a patient who is having a severe pain. You cannot start from the baseline and go upwards. Like, you have to address, if it's a severe pain, you have to address it well first and go down or assess accordingly. So coming to the pharmacological class of drugs, the common one that we see in many pharmacies is acetaminophen, or what we call paracetamol, or it's an analgesic and antipyretic agent that mostly lacks an anti-inflammatory property, but it has good GI tolerability, and it's usually used for mild to moderate pain and in combination with other drugs like Percocet, as you remember, and it could be combined to be given with opioids and to treat severe pain. So it's usually suitable for both pediatric and adult patients, and it has minimal side effects, which is a good thing. So the maximum dose is 4 grams per day, and in adults, and also 10 to 15 milligrams per kilo up to 4 times a day in children. So this could be given easily, and it has better results when it's combined with other analgesics or other potent analgesics. So the other class is non-steroidal anti-inflammatory drugs. So they're used in the treatment of mild to moderate acute pain. So what they do is they inhibit the cyclooxygenase pathway of arachidonic acid metabolism, and thereby limiting prostaglandin and thromboxane production. So there are two COX isoforms, and currently a third one is also implicated, but these are the main two. So what accounts for pain, inflammation, and fever is the COX-2 pathway, and there are many drugs which inhibit both, so they are called the non-selective COX inhibitors, and what they do is they will relieve pain, inflammation, and fever, but they will also compromise the GI protection and hemostasis, which is mainly mediated by cytoprotective prostaglandins, and also they inhibit by platelet aggregation, leading to bleeding, or those are the side effects that are implicated. So the main adverse effects in surgical patients are GI hemorrhage, which could be occasionally catastrophic, and renal dysfunction or failure. And this is because the prostaglandin has nature of vasodilation in glomerular bed. So this doesn't happen always, but you have to watch out for the patients who are prone to this, because mostly it's associated with prolonged use, and in those who are hypovolemic or who are impaired renal function, or impaired or deranged serum electrolyte levels. So the other is decreased hemostasis and hematoma formation. Also, there is a decreased healing of the GI anastomosis, which is proposed, not always true. And also, some patients or some physicians avoid it because of delayed, unimplicated delayed fracture healing. And this is mostly like with on paper levels, that this is mostly like, this needs detailed studies, and this is associated with prolonged use. So they are very good analgesics, for example, in our setup, because they're cheap and easily available, and they could be used for multimodal analgesia as well. So passing to the opioids, which are main class of drugs that are used to treat acute pain. The morphine is the most commonly prescribed opioid in hospital, as you know. So it's usually metabolized to morphine-3 glucuronide, which is inactive, and morphine-6 glucuronide, which is an active metabolite. So this happens in the liver and kidney, so you have to watch out for it in liver and kidney impairment, and usually in renal failure. So prolonged respiratory depression with small dose could happen due to metabolite buildup, the active metabolite. So fentanyl is a synthetic derivative of morphine, and it's 100 times so more potent. It's lipophilic, while morphine is usually hydrophilic. So this has a more rapid onset of action, which is about 2 minutes, and this is due to improved penetration of the blood-brain barrier and a shorter time to peak effect. So fentanyl does not release histamine. Morphine has that side effect, and this may precipitate hypotension in prone patients, and also bronchospasm is possible due to histamine release. So duration-wise, fentanyl stays about for an hour or 30 minutes to an hour, and morphine has longer duration, which is like 4 to 6 hours possibly. Hydromorphine, or dilaudid, known as dilaudid again, is a better tolerated version. It's more or less similar to morphine, but it's slightly more potent. So it's preferred over morphine for renal disease patients. It has a low cost, and IV and PO forms are available. And oxycodone, as I told you, it can be available as Percocet, which is a combination drug as oxycodone and acetaminophen. It has a good side effect profile, but it's costly, and it has pure forms only. So passing to codeine, it has tens of morphine's potency, and it's metabolized into morphine by the body, and it's there are different genetic isoforms of the enzyme that metabolize codeine. So it's metabolized by the hepatic enzyme system of CYP2D6. So it could be ineffective in 10% of Caucasian patients, and in some East African population like ours, it could be, there are some ultra metabolizers and possibility of side effects such as like alpha metabolizers, which has two genomic alleles of the drug metabolizing system. So they are prone to the side effects of the drug, such as respiratory depression and more of the other side effects. So codeine is, I don't think codeine is currently available in our country. So the other is meperidine or Demerol. So it's mostly avoided because it decreases seizure threshold and cause dysphoric reactions, and this is due to some of the neurotoxic metabolites such as normoperidine, which accumulates in renal impairment. So some of the common side effects of opioids are regarding the airway. They could cause bronchospasm and cough suppression, and this is one of the results of histamine release again. So breathing, they can cause they work usually by mu and kappa receptors, and they have different side effects. So the breathing system, so the respiratory depression is the main side effect that they cause. So this usually happens in larger dose of some drugs and with impaired clearance. So you have to watch out the dose that you give. So in cardiovascular system, hypotension is possible due to histamine release, and gestal rigidity is a rare side effect. So CNS sedation with buildup can occur, and dermatologically pruritus with again histamine release is possible. And in GI, nausea and vomiting with biliary spasm, pruritus, and constipation are possible. So urinary retention is also possible with opioids, especially like with intrathecal or neuraxial use of opioids. So the other issue with opioids is the issue of tolerance, dependence, and addiction. So these words are like somehow similar but different concepts. So drug tolerance arises when you have to use an extra dose to create an analgesic level that was previously achieved with a smaller dose. So now you need an increased dose. So it arises through a combination of receptor desensitization and psychological factors. So dependence or physical dependence arises after chronic opioid use, and it's usually resides in the norepinephrine pathways of the locus coeruleus. And when a drug is withdrawn in dependent patients, it typically produces withdrawal symptom or withdrawal syndrome. And this could be by activation of the sympathetic system. Patients might be agitated, they might be sweating, they might have their sympathetic system going up. So the other issue or the other concept is addiction. So this is a primary chronic and neurobiologic disease, and it's characterized by behaviors that include impaired control over drug use, there is compulsive use, and there is continued use of drug despite harms and cravings. So these issues are managed differently. So we could also give analgesics in a patient-controlled analgesia, or PCA as we call it. So this technology gives patients relative freedom, and it gives control over the analgesic medication without nurse intervention, and it has built-in safety features. So you could give a bolus dose or a constant infusion rate, and this will allow to titrate a patient's drug level in a certain manner. So it allows patients to reach their own minimal effective analgesic concentration, and it has better analgesia with less side effects because it has also time for lockout intervals so that you will not overdose, and you won't have to give IM and PRN as well. So as you can see on this graph, there is PTA with the red line, and the analgesic level is usually on a certain level, or the serum concentration of a drug is on a certain level, while there are peaks and troughs with intermittent IM and IV bolus. So it helps us to control, or it helps us to develop an optimal plasma concentration. So this is a PCA device. As you can see, there is a place for a syringe insertion, or there is a screen displaying, and also you could fill the numbers on the pod. So another drug is gabapentin, which are calcium channel blockers, and they are they block the alpha ligand of the calcium channel. Usually they are like antiepileptics, but they could be used as adjuvants. And also it's another drug is pregabalin, which has a better bioavailability than gabapentin, and a common starting dose for gabapentin is about 300 milligrams, and you could go up to 1200 milligrams. And if given before several hours before the surgical procedure, it can reduce acute postoperative pain by 20 to 60%, and they're usually effective for neuropathic pain as well. So the main good thing about this is they reduce the consumption of analgesics, also postoperative opioids, on the incidence of postoperative delirium, nausea, and vomiting as well. So this is possible. And the other class of drugs are NMDA receptor antagonists. Ketamine is the most famous one. So NMDA receptors are known to reduce central sensitization, hyperalgesia, and opioid tolerance. So these are one of the drugs used in patients with chronic pain and opioid tolerance. So this makes them an attractive option to treat acute pain. So by reducing central sensitization, they reduce postoperative pain and the likelihood of developing chronic post-surgical pain. So ketamine is an NMDA receptor antagonist. So it acts by decreasing the absorption of the norepinephrine or catecholamines uptake. So it's metabolized in the liver predominantly by the CYP3A4 into norketamine, which is an active metabolite. The good thing about ketamine is that given in the right dose, it has a good side effect profile. I know it's there are some hallucinogenic effects, but with the right dose, there is no respiratory depression, and it could be combined with other drugs as well. So, which is a good thing for infusion as well. So you could start ketamine in the range of 0.5 to 1 milligram per kilo per hour. So another drug is the local anesthetic lidocaine, which can be given in an IV infusion. So there are IV forms prepared. So they act by blocking voltage-gated sodium channels, resulting in inhibition of nerve conduction, but also reduced inflammation and central sensitization. So they have been shown to reduce opioid consumption by as much as 85%, and they improved resting and active pain scores. Also, they reduced nausea and vomiting, and there was an accelerated bowel movement recovery. So typical infusions can be started as 1 to 1.5 milligram per kilo per hour, and you could check serum level if you have it and titrate it according to that. Another versatile drug is magnesium sulfate. So magnesium is a non-competitive NMDA receptor antagonist and calcium channel blocker. So it is a safe drug with a high therapeutic index, and nowadays growing number of papers are mentioning magnesium sulfate infusion as an adjuvant. So these drugs that I mentioned, such as the antiepileptics, lidocaine, the ketamine, magnesium sulfate, are called as an adjuvant in a group. So in terms of potentiation of pain, so postoperative analgesia, so it can be used as a muscle relaxant. It decreases inhalational anesthetic requirements, opioid requirements. So also the sympathetic drive has been shown to decrease with its use, and not only opioid consumption, but improves pain scares as well. So you could start usually 30 to 50 milligram per kilo as an IV loading, and you could go with 6 to 20 milligrams per kilo per hour as a continuous infusion. So even single bolus improve patient comfort, improve pain sensation. So coming to the interventional techniques, there are not much slides prepared for this session, but I just wanted to know the concept of epidural anesthesia. So epidural anesthesia or epidural analgesia could be given by insertion of epidural catheters in the lumbar, thoracic, or abdominal part of the spine, and they give you lower extremity pain relief or pain from different post-operative or post-surgical conditions, and they are very safe, and they have few complications which can happen, like the drugs that we use are local anesthetics and opioids or other adjuvants. So with that, hypotension is possible, and with use of opioids, urinary retention is possible again, and with local anesthetics, higher dose, motor blockade can happen. And the other risky complication is epidural hematoma, which doesn't happen always, and which is common, which happens, if it happens, mostly in patients who are on anticoagulant drugs. So there are also the concepts of regional nerve blocks, which we do for post-surgical patients or even for surgery. So they improve patient outcome and comfort and pain scores. So you could do an upper extremity block or an abdominal blocks like a transverse abdominis plane block and other different blocks, nerve blocks, to improve pain. So if you give a pain or if you give a patient different modes of analgesia, or you'll improve his stay and you'll improve his you'll improve his outcome. So these things, the concept of multimodal analgesia should be encouraged at any one time. So in summary, pain is a subjective experience. I'm going to stress this out again and again. So just don't underestimate what a patient tells you. So what might be severe for him might not be for me, but I have to take his word. And untreated pain is a common cause of chronic pain. So we have to aggressively address acute pain, and this helps us in preventing chronic pain. By the way, the rewiring or the neural mechanisms have been shown to happen if in short duration, as much as an hour, like the sensitization, the central sensitization, and these things can happen. So pain also should be assessed, addressed, and evaluated for response. So that's what we track. Patient's response is what we track, and again, we have to address if it's not sufficient. Okay, so multimodal analgesia should be given again for pain relief, and it improves patient recovery. Also, drug side effects will be cut, because we're going to use a lower dose of many drugs or multiple drugs. So this will prevent from side effects from causing a problem. So this was my presentation, and these were my reference again. Thank you so much, and I think we'll proceed to the question and answer. Okay.
Yeah, thank you so much, Doctor. So participants who are asking in the chat box, please write your questions in the Q&A only. So Dr. Sofoniyas will address those. So let's pick a few questions which you think that are not addressed in the presentation. So since we have an idea.
So, okay, I think I see one question. So which pain medicine suggests for patients with acute coronary syndrome? So here acute coronary syndrome is one of the medical causes of acute pain. So it's an acute nociceptive pain. So we use potent drugs, okay? So like the drugs that we commonly use are morphine, which treats pain. So you have to decrease the oxygen demand and the myocardial oxygen requirement of a patient. So also the coronary vascular bed should be improved. So we add nitroglycerin to that added. So we give potent medications in there. Okay, their pain scores are high, and we have to decrease the sympathetic stimulation that comes because of an increased pain stimuli. Okay, thank you. So there is another one. How can we select the best pain management methods? Okay, so for me, the best pain management method is to ask the patient, assess his level, and design a plan. Okay, so design a plan so that a patient can benefit greatly from your service. So the plan that you drive for some conditions might not work for the others. So use a combination of drugs, and don't neglect the like the drugs that we have, the simple one, like for example, we have an easily accessible paracetamol in our ICUs or in our hospitals, right? So you could combine that with an opioid or another class of drugs, use of adjuvants, and you could come up with a plan to treat your patients. And the other thing is to assess his response. So if he has severe pain, you go for, like, you aim higher and shoot higher so that you could address his pain in a timely manner. Then you could go down again, okay? So you could, there's no best way like mentioned. So you could proceed with a tailored plan. So, okay, how much effective are the pain assessing scales? Okay, so the best way to assess pain is by the patient's self-report, okay? So the self-reporting is the best way. So difficulty arises when you are communicating with, when you're having a non-communicating patient, such as, for example, in intensive care or in a non-communicating child. So you have to use some behavioral patterns and, for example, muscle tension or ventilator synchrony, and you have to use different pain scales. So they're effective. So it depends on your usage, but they're effective. And one thing is, the scales that I showed here are unidirectional. So they just show the intensity, but they don't tell you the quality of pain. So the descriptive scales, which we didn't mention here, are available, and you can use that so that you could see and combine patient comfort as well. So again, what's pain management for unconscious patients? So one of the pain management skills that we use in the ICU are the critical care pain observation tool and behavioral pain scale. So we could use that again. So, okay. So based anti-pain for GI pain. So we could use, like, I always go for multimodal. So neuralgial techniques have been used for extensive surgical techniques, but we could use again, like opioids, paracetamol, combination techniques. I wouldn't suggest any specific drug. And the other one, can we treat labor pain with single opioid intrathecally in less developing countries? Yes, we can treat. So when a patient is about to go, like at the second stage of labor, like you could give a single shot spinal with local anesthetic, a very small dose, and that will be very effective. Or also you could add opioid to that, and it will it definitely will help. And for example, also, like when you do spinal cesarean sections, we give local anesthetic and opioids to treat also the post-surgical pain as well. And why is epidural not implemented in our country? So epidural is currently being implemented in some hospitals, and mainly if it's not implemented, it could be due to the financial issues to buy the epidural kit and the skills. Currently, there are many anesthesiologists being trained, and they can give the service. And I think it's mainly financial, but it's being implemented in its expanding service. So again, which one is the best assessment? So in adults, you just have to ask the patient. That's the best way. So if he's communicating, ask the patient to quantify and describe his pain. And okay. What are role of nurse in pain management? So nurse can be trained on how to assess and treat and look for side effects. So definitely nurse have a role. So what's about the type of pain in acute abdomen? So these are like acute pain, definitely. So there is the somatic component and the visceral component, okay? So the somatic one is a very sharp one, and the visceral one with distension of the viscera, it comes from will be the visceral component of acute nociceptive pain. So pain management in PACU, who's responsible? Everybody who works in the PACU is responsible, okay? So the nurse, the physician, like, or the anesthesiologist or the anesthesia service provider is responsible. Okay, so we have, okay, so what do you think about intrauterine fetal pain? Okay, so this is a broader topic. I think we have to look up to that, and we'll update you. So, okay. And okay, what's the maximum dose for diclofenac and tramadol? We usually like give like tramadol in QYD base with around, I think, 2 milligrams per kilo. So why not? Morphine has a maximum dose. So morphine has like what I feel, what I was saying again is you have to act like if a patient, for example, if you give me 5 milligrams of morphine and if it doesn't work for me, that doesn't mean I have to average my limit. Okay, so these things they should be improved, and this should be understood. Okay, so the fact that I feel pain, I don't like the fact that I feel pain with 5 or 10 milligrams of morphine doesn't mean I have reached my limit. So if there's pain, you have to address it. Okay, so just have to watch out for the side effects. Is there a place? Okay, is there a place for? Okay, is there a place for steroids in the management of pain? Yes, of course. We use dexamethasone, for example, in the management of pain, and this is like one of the effects is because it's usually an adjuvant, and it's also acts on prostaglandin release. So it's one of the adjuvants that we use, and they definitely have pain adjuvant management role. Is codeine available nowadays? I don't see codeine nowadays. Okay, so which analgesic is recommended for neonates? We mostly use rectal suppositories, but in severe, when we anticipate what we call when we anticipate severe pain, we go with opiates as well. Is it possible to assess pain objectively? Objectively, yes, of course. That's why we're using scaling methods. Okay, so we can use also we can use definitely. So what can be done? Okay, so what can be done for a patient having a phantom pain? So there is this has some psychological component to it. So sometimes what they use is mirror therapy, and also the sensation that comes from a limb that has been severed is there is an afferent transmission going on, and there is no impulse coming back. So there is a misconception or a misunderstanding in the brain. So they train it with a mirror therapy, and these patients get relief with that. And might work for some people, might not work for the others. And okay, is it contraindicated to use diclofenac drug in patients with hypertension and cardiac patients? Diclofenac is an NSAID, so what do we fear with NSAIDs? So for cardiac patients, it's not diclofenac. That's as far as my knowledge, it's I think that the COX-2 inhibitors that have been withdrawn from the market, such as rofecoxib, and those were in patients with also who had coronary bypass. And I don't think there is a reason the main issue with NSAIDs is the duration or the condition, the side effects. When you're anticipating the side effects, you have to check the patient's condition. So if you're anticipating other risks, you might as well reduce the dose or use an alternative. Okay. So some say that we can manage labor by epidural analgesic. Is it possible? Yes, we can. Yes, we can. We can address labor pain with labor epidural. It's being done nowadays. So to what extent subjective report of pain scale is in children reliable? So some children, like as far as even the age of 3, they might tell you their feelings. So they might tell you their feelings, so you have to take it. So if they tell you, definitely. Some I know maybe like may like to isolate in case of pain, but definitely if they tell you they have pain, you just have to dig for it. And one point to add in children is the fact that the parents may tell you their character. Okay, so for example, if a child is hungry and there might not be pain, oh, the parent may tell you that, oh, he's kind of hungry. Okay, so if he feels pain and if he's complaining, they know the child's behavior. So you could also dig with their parents about how the child is feeling and if he's feeling odd. Okay, so okay, and also okay, parenteral anti-pains for pediatric patients. Yes, we use opioids again. Also, we definitely use opioids mostly here. Okay.
All right, Doc. Let's pick our last maybe 2 questions.
Okay.
And let's go.
2 questions. Okay. So, okay, what do you suggest on monitoring for opioid-induced respiratory depression in our setup? Thank you. So, opioid-induced respiratory depression. So, we have to watch out for patients who are at risk for opioid-induced respiratory depression. Okay, those are usually those patients at extremes of age, those who have obesity or obstructive sleep apnea, resulting obstructive sleep apnea with impaired organ function, and like you have to watch out the patient groups. Okay, so you have to take those into consideration, and titrate your dose of drugs that you're giving. Okay, so you could start from the lower one, and if you necessarily have to use them, you could start from the lower range. And also if there are other options, and you could use those again. Okay, sorry, one more. So, okay, risk of substance abuse of opioids. Okay, so definitely nowadays we're having the issue of substance abuse. So most of even the weak opioid tramadol was being abused, right? So you have to limit the access and decrease. Definitely, like the potent opioids are definitely prone for abuse. So that's why they are restricted in another prescription, and there are ways to give them to what we call like to patients. So we have to have a safety strategy. So the main issue of substance abuse, or like not substance abuse but opioid abuse, is mostly in chronically ill patients, because at one point or the other, mostly chronically ill patients tend to have like with a prolonged pain management, for example, chronic neuropathic pain, you might use opioids as well. So in the longer run, they might develop dependence or tolerance, and these are the patients we have issue with. So definitely we have to use alternatives. So opioid reducing strategies should be implemented. So there is the risk. Obviously, there is the risk. Okay. So management of headache after spinal anesthesia after CSF Panadol fails. So mostly it's what we call like the word patients have to lie supine, okay, hydration, supportive medications, supportive therapy is the mainstay. So lying supine with also like giving drugs such as Paradol and Panadol also helps, and hydration also helps. So there is like if all options fail, there is also the point where we reach epidural patch. I think you're implying to that. So this is one of the, this doesn't usually happen, but there's the possibility of epidural blood patch being given if all measures fail and patient has functional limitation as well. Okay. Okay, I think this will do.
Yeah. Thank you so much, Doctor, for giving your time for this amazing presentation. Also taking quite a good amount of time for the Q&A. A lot of our participants are giving their thanks in the chat box. So on behalf of our participants and from on behalf of Blue Health, we would like to give you a huge thanks. And we hope to see you in another setup or in another platform. So if you have any last message, we'll give you we'll give you the stage once more, or if not, we can conclude and you can leave the session. And participants, for the participants, we will post the quiz and they can take it.
Okay. For everyone, like what I want to tell you is that this is a pain management is a very, very big topic and we cannot cover it with a single session. So that's why we chose acute. Even acute pain management is a very, very broad topic. So you can check different papers or like text for, but one thing for sure is we have to manage pain. And as from my experience, we're very with pain, but pain should never be underestimated because like definitely it will have consequences. Okay, so we have to use that. And I'd like to thank you all for attending. Okay, thank
All right. Thank you so much, Doctor. Have a good night.
you so much. Take care. Have a good night. You're welcome. All right.